Video. So today we're going to be talking about fractures, the type of fractures, and a classification of fractures, what the clinical signs are, diagnosis, and how we would open and close reduction for them. So what is a bone fracture? A fracture is a break in a continuity of a bone. Often you can see a bit of an angle from the longitudinal axis of the bone. But you know, a fracture is a break in the continuity, the linearity of a bone. What's a dislocation or a luxation? This is a displacement of the articular surfaces of a joint. Now you can dislocate a joint, but what does that mean? A joint is often you can get a hinge joint, and whenever you have a joint, you have two things connecting to one another through a joint. So two bones, for example, you have articulating surfaces of both, and if you have the articulating surface of one and the articulating surface of another, for example, the humerus in the glenoid cavity, if you have displacement of the humerus, that would be a dislocation. A subluxation is from a dislocation. It's a subluxation. It's a partial displacement of the articulating surfaces of a joint. What's a sprain? A sprain is a joint injury in which the fibers of the supporting ligament are ruptured, but the continuity is intact. We'll cover that in a bit. So here's a fracture. You can see a fracture. It's a break in the continuity of the bone. It's a break. You can quite clearly see two different pieces of the bone. This is a transverse fracture because it's going across. Okay, it's going across, and it's complete all the way through. A dislocation, like I said, this is actually the humerus, and here's the olecranon, and here this is quite clearly a displaced humerus. You can see the humerus, the articulating surface of the humerus, which is here, the articulating surface of the olecranon. They are far from each other. There's a space, there's a dislocation. What's a subluxation? Well, here you can see the phalanges. Here you can see a subluxation. It's it's partially dislocated. It's partially dislocated the metacarpophalangeal. This is the interphalangeal joint, right? It's partially dislocated. It's not completely, because that would be known as a dislocation. When it's partial, it's known as a sub less than luxation. A bone totally being displaced, as we said, is a dislocation. What do you think a partial dislocation is? It's a subluxation. And when you're injuring the joint, you're not dislocating, you're not breaking, you're not fracturing. When you're simply injuring your joint, it's a joint injury, and you have ruptures of some of the fibers, it's known as a sprain. Sprain injuries tend to affect the connective tissue, the ligaments, the muscles. Here's a sprain. An ankle sprain is when you damage the ligaments of the ankle. Remember, what are ligaments? Ligaments are like glue. They're like these connective tissue glue structures that connect one aspect of a bone to another bone. Okay, that's what a ligament is. And if you damage the ligament of the ankle, remember, you're not damaging the bone, you're not damaging the joint, you're damaging the ligament. So, you are getting joint injury, but it's not a dislocation. Do you see? So it's a joint injury in which some fibers of the supporting ligament are ruptured, but the continuity remains intact of the bone and of the ligament as well. What is the anatomy of a bone? So you want to remember that the shaft of a bone is known as diaphysis. Diaphysis, the longest part of a bone is the diaphysis, the shaft. Then you have the epiphysis and the epiphysis on both ends, and you also have an epiphyseal line from which growth occurs, or the epiphyseal plate, as it's known earlier when growth is occurring. You have a metaphysis. You have a proximal and distal metaphysis, and this metaphysis is right before the epiphysis. What are the fracture types? So what you came here for? You can get a transverse fracture, which can be non-displaced or displaced. Displaced would be a complete, and this would be incomplete. That means that the bone is completely torn apart. A transverse fracture, you have a compound fracture. Nowadays, most professors like to call this as an open fracture, something which can break through and protrude through the skin. And you can imagine this is someone's leg, and this is the femur, and you can imagine that a part of the femur would be protruding outwards, and that would be known as an open fracture. Then you have an oblique fracture. Then you have a comminuted fracture. A comminuted fracture is when there is a break in more than one area. It's a fracture with three. Let's be specific. It's a fracture with 1, 2, 3, 4. Here's 4, but the definition, comminuted, is with a fracture with 3 or more pieces. Then you can get a Greenstick fracture, which is when there is a fracture on one side, but the bend is towards the other. So I have a better image of that one, okay? So this is a transverse fracture. When it comes to a transverse fracture, this is the long axis of the bone. So if this is the tibia, here's the long axis of the bone, and the fracture line you can see is here, and this is known as a transverse fracture because it's almost at perpendicular or right angles to this long axis of the bone. What's a Greenstick fracture? A Greenstick fracture is often seen in children, and what you will see is you will have a fracture on one side of the bone. Here's one side of the bone and here's a fracture. The other side of the bone will be bent, and the other side of the bone is bent. So one side of the bone is fractured, and what you'll notice, what's significant, is usually when you have these fractures, the side of the bone with the fracture on is usually the one that's bending. But what we do see in a Greenstick fracture, one side is fractured and the other one is the one that is bending. Okay, and it's often seen in children because, see, children have more flexible bones. Their bones are flexible. They don't have complete growth yet, and the epiphyseal plate is still developing. So this is known. Why is it called a Greenstick fracture? Because like a branch or like a tree branch, here you might have a break, but it's going to bend on the other side. Okay. Spiral fracture, the bone has been twisted apart. Here you can see, and you can see that the long axis of the bone has been deviated. You can see it's deviated. Butterfly fracture, this one's an interesting one. This is when the bone has a butterfly-shaped or a wedge-shaped fracture fragment. So the fragment you can see is like a butterfly spreading his wings, okay? Comminuted fracture is a fracture with 3 or more pieces. This is an absolute horror. This is too many. This is kind of quite serious. This one is. So 1, 2, 1, 2, 3, 1, 2, 3, and a bit more fragment here as well. Compression fracture. These tend to occur in the vertebrae. Compression fracture is when there's a sudden, excessive vertical force coming through the vertebrae. Vertical force, it's excessive, and it's causing compression fractures to occur on the vertebrae, and the vertebrae breaks into a little piece. What is an open fracture? It's one where you can see the bone protruding and you can see a wound which has an outside and inside. A closed fracture is when you don't see anything protruding to the outside. When it comes to these epiphyseal fractures, we have something called the Salter-Harris classification, which sounds complicated, but it really isn't. Salter-Harris is very easy because you can remember it with Salter. So remember, Harris was a salty guy. Salter had because he fractured his tibia, or he fractured any of his bones. So you have a growth plate, which is known as the epiphyseal plate. When you have a growth plate, you often get these transverse fractures. Now you'll notice you have SALTER, and these are the stages. So this would be stage 1, this would be stage 2, this would be stage 3, stage 4, and stage 5. There's 5 stages, each starting with a letter of that I've mentioned. So growth plate is here. This is the epiphyseal plate. This is where you have growth from. Now, if you remember from the earlier diagram that we showed, this would be the metaphysis. Above it would be the metaphysis. Okay? So, while that would be a metaphysis here, the growth plate is only disturbed if you start to damage the base of it too. So you'll understand what I mean. So the growing zone, is the growing zone affected or not? That is the crux of this classification. Will growth actually be disturbed? Will you have significant growth disturbance? So let me give you a heads up. Only in stage 4, where you have TE through everything, will you have a potential for growth to be disturbed because it will interfere with this growth plate. Whereas here, you will have a much more serious cause for concern for significant growth disturbance because it will crush the entire growth plate. Okay, so the green is the growth plate. What is S, type 1? Straight across, it's a transverse fracture, which is along the line of the physis, but as the growing zone, which is over here, is not injured, there is no growth disturbance. This is straight across. Once again, what does it mean to have straight across type 1? Is that you have a straight across transverse fracture of the physis without disturbing the growth plate, therefore no growth disturbance. Then you have above. Above means above the physis, and what part anatomical zone is above the physis? The metaphysis. So this is a fracture line which is deviating into the metaphysis. It's starting here. Remember, all of these tend to affect the epiphyseal line, but not all of them completely shatter the epiphysis. So this is above, you're affecting the physis line, but you're also, so this is similar as type 1, but you're deviating the fracture into the metaphysis. No significant growth disturbance here. Then you have lower, straight across, above, lower. Now what are we seeing? Now we are seeing that in lower, there is, it's deviating into the, so actually I said something wrong here. When in above, it wasn't deviating into the epiphyseal plate, okay? The epiphyseal plate was completely fine, only the metaphysis in above, because it's above. When lower, you are now affecting the epiphyseal plate, you're affecting the intra-articular epiphyseal plate, but there's no significant growth disturbance. Then through everything, this is a big fracture. The fracture line is crossing the physis, sometimes crossing the metaphysis, crossing the physis, crossing into the physis, after crossing through the metaphysis, crossing through the physis, going through the growth plate. And if the growth plate is displaced, and you can see here it is, here the growth plate is completely displaced, you will have growth disturbances. So it all depends on how much the growth plate gets displaced. Finally, you have R for crush. SALTE, R for crush injury of the physis. This is going to completely damage the physis and cause significant growth disturbance. Hope that was good. Moving on, the fracture features. We will see pain and tenderness. We will see warmth and swelling. You will see bruising. You will see abnormal attitude, which means, for example, if the shoulder was normally in the normal physiological attitude, abnormal attitude would be in anterior dislocation. It will be abducted, externally rotated. Shortening of a limb, and crepitus. Crepitus is the grating sensation, the grating feeling you get on palpating when the bone ends rub against each other. And obviously, what makes a fracture different to any other bodily organ, what's a very important clinical feature of a fracture is you will have loss of function. Examinations. No exam of a fracture is complete without you must examine the neurovascular aspect of the distal aspect of the limb. So if you have an upper arm fracture, you want to check your pulse, you want to check your nerves in your distal, in your forearm. Okay, you always want to check the pulse and the nerve, neurological exam, distal to this limb that is fractured. A fractured bone is a problem, but the loss of distal perfusion would be a disaster unless it's recognized and treated promptly. When you examine, you want to do an investigation called radiology. You want to do x-rays. You want to do the rules of twos. Two views, AP and lateral, 2 joints, proximal and distal, and 2 sides. So if you damage the tibia on one side, you want to check the other tibia as well to compare. Always compare, because people can have they can have deformities that they're born with. But remember, rule of twos for x-rays, 2 views, 2 joints. You want to check the proximal and the distal joint at all times, and 2 sides. General management, you want to give pain relief, splint the fracture. You want to give blood transfusion if they're in hemorrhagic shock. If there's any kind of road traffic accident, motorcycle, bike accident, you want to give a tetanus toxoid vaccine. Tetanus toxoid. And you want to give antibiotics. You want to give 3 types of antibiotics. You want to give 1, cephalosporin ceftriaxone, 2, metronidazole, and 3, amikacin. Metronidazole is for the anaerobes. Amikacin is the aminoglycosides for the gram-negative coverage. Specific management of a fracture. You want to do first aid ATLS. I don't know why I just got so excited, sorry. Okay, you want to do ATLS, first aid, airway, breathing, circulation, disability, exposure. Then you want to, if you are experienced, you can try and reduce the fracture. Actually, don't try. Only reduce a fracture if you're comfortable with that, if you're experienced with that. Then you have reduction, stabilization, and rehabilitation. What is reduction? Reduction is when you're realigning the fracture site. You're realigning. Remember, our bones are always in a line, in a long axis. You want to realign it back to the normal anatomical position. Reduction can be in two ways. It can be open or closed reduction. If it's open reduction, the wound is exposed. The fracture is reduced under the surgeon's vision and surgically exposed bone. When it's a closed reduction, the fracture is manipulated from the outside, so there's no surgical exposure. How do you stabilize? You can do a splint or a cast. This splint or a cast is very important, but remember, you only apply, important thing for a plaster of Paris. When you're applying a plaster of Paris cast, remember, you're applying the plaster slab only to one side of the fracture, so that the other side, there's leeway, there's space for edema and space for the swelling. And if you were to leave that, you need to do that, and you don't want to cause compartment syndrome, right? So plaster of Paris is used. If there's soft tissue swelling, then only a back slab or splint plaster is used to prevent compartment syndrome. Traction is when you are taking your distal aspect of the limb and you're stretching it out, because the concept here is stretching out the limb, applied to the skin or to the bone. When you're stretching it out, distal aspect of the limb, it helps to stabilize. It helps to stabilize the entire reduction process. You can use internal fixation, external fixation. So when it comes to fixation, an external fixator is when you have the screws attached that you can see outside of the body. You have this external fixation without openly doing it. This is when you have pins and wires and those screws connected to the limb by a fixator, but on the outside. External fixation, screws and pins outside. Internal fixation is different, because you're going to do an open reduction. You're going to internally fixate the fracture yourself. So I hope this was useful. This is an open reduction. This is an introduction to this topic. Thank you.